Greetings, I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's July 2018 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlight articles. Our Editor's Choice is an original article that utilizes voice signal analysis, an emerging non-invasive diagnostic tool to determine whether patient voice signal characteristics are associated with the presence of coronary artery disease. It is authored by Dr. Mayo and colleagues from Mayo Clinic in Rochester, Minnesota. The study population included 166 patients who were enrolled between January 2015 and February 2017, and which included 129 patients who underwent coronary angiography. Patients who underwent coronary angiography were referred to the chest pain clinic and were not known to have pre-existing coronary artery disease. Control groups were included to improve overall quality of voice features normalization and to exclude the possibility of bias associated with pre-procedural anxiety. These control groups included subjects undergoing no procedures and those subjects who underwent non-cardiac procedures. Each subject spoke aloud a predetermined amount of text into a recording device with no prior training or coaching. A total of 3 30-second separate baseline voice recordings were analyzed for each participant. First, a pre-specified text. Second, a description of a positive emotional experience. And third, a description of a negative emotional experience. Voices were analyzed for multiple features of voice intensity and frequency using the Beyond Verbal Communications clinical trial application, which was downloaded to the patient's smartphone. The voice analysis was done in a semi-automated fashion, and all voice files were examined by a voice analytics expert. A defined set of acoustic features was extracted from each voice file. The primary endpoint was coronary artery disease, with the study population divided into those with or without coronary artery disease. A univariate model was applied separately for all 81 voice features of the 3 baseline recordings. The analysis revealed 5 voice features that were associated with coronary artery disease in at least one of the 3 baseline recordings. There were no differences between healthy subjects and patients with coronary artery disease as regards the remaining 76 features. The strongest association between voice and coronary artery disease was observed when patients were requested to record their voice while describing an emotional experience. This association was independent of age, sex, and other traditional cardiovascular risk factors. This study is the first to describe an association between voice characteristics and coronary artery disease. The authors conclude that this holds the potential to assist physicians in estimating the pretest probability of coronary artery disease among patients presenting with chest pain, especially in the setting of telemedicine, the latter providing clinical health care at a distance. This article is accompanied by an editorial by Dr. Sugru and colleagues from Mayo Clinic in Rochester, Minnesota. These authors begin their editorial by envisioning a virtual household scenario using the emerging technologies of telemedicine and artificial intelligence to diagnose patients at a distance. They emphasize that telemedicine is thriving because it enables healthcare delivery to relatively inaccessible and under-resourced areas, and it provides healthcare with less day-to-day interruption for patients. Additionally, the potential of these technologies is just being realized. For example, in those vulnerable populations such as babies or the elderly, where voice analysis and other detection systems may monitor their current condition at a distance. Dr. Sugru et al. Underscored that voice analysis could be easily integrated into current technological platforms such as a smartphone, thereby enabling its transmission to processing areas, and, along with the emerging tools of telemedicine and artificial intelligence, voice analysis may offer remarkable and expanding opportunities for diagnosing cardiac and other human diseases. Our first highlight article is an original article that examined whether persistent bilateral global nephrograms are associated with acute kidney injury, dialysis, and mortality. It is authored by Dr. Jennifer McDonald and colleagues from Mayo Clinic in Rochester, Minnesota, and Jacksonville, Florida, and the University of South Carolina in Charleston. Prior studies report a correlation between persistent global nephrograms and the development of acute kidney injury. However, the poor correlation of changes in serum creatinine levels as a biomarker for acute kidney injury may cloud the potential relationship between nephrograms and renal injury. Moreover, prior studies examined very small numbers of patients, and none of these studies address whether there is an association between nephrograms and other outcomes besides acute kidney injury. The authors identified all patients who received, first, a contrast-enhanced computed tomography CT exam or cardiac catheterization with iohexol between January 2000 and December 2014, and second, a non-contrast abdominal CT exam in the subsequent 24 hours. Nephrograms were identified by radiologist review and CT attenuation measurements. Univariate and multivariate analyses were performed to determine nephrogram risk factors. AKI, defined by an increase in serum creatinine of 0.5 milligrams per deciliter or greater, or AKI stages 1 through 3, dialysis, and mortality proportions were compared between patients with and without bilateral global nephrograms. A total of 123 patients met all inclusion criteria. The proportion of patients with a nephrogram was 37%, with a higher proportion following interventional versus diagnostic catheterization or contrast-enhanced CT. Age, chronic kidney disease, and acute hypotension or shock were significant risk factors for nephrogram development. Nephrogram patients had significantly and markedly higher rates of acute kidney injury, dialysis, and mortality compared to non-nephrogram patients. The presence of persistent bilateral global nephrograms thus associates with an increased risk of acute kidney injury, dialysis, and mortality when compared to patients whose kidneys fully and rapidly eliminated the contrast material. These findings indicate that the presence of a persistent bilateral global nephrogram may be a good marker of renal injury after exposure to intravenous contrast material. The second highlight is an original article which examined the relationship between estimated cardiorespiratory fitness using non-exercise equations and all cancer mortality in a representative sample of the U.S. population. It is authored by Ms. Yin Wang from the University of South Carolina, Columbia, and colleagues from national and international institutions. Cardiorespiratory fitness is an indicator of general health. Epidemiologic studies have found that cardiorespiratory fitness is inversely correlated with all cancer and cancer-specific mortality. There are limitations, however, in such studies. The first involves the generalizability of these findings to other patient populations, and the second stems from the fact that cardiorespiratory fitness is mainly quantified in these studies as metabolic equivalence, the latter requiring exercise by treadmill or cycle ergometer. To avoid the need for exercise testing, these investigators in the present study use non-exercise models. A total of 8,506 study participants were derived from the third National Health and Nutrition Examination Survey, conducted from October 1988 to October 1994. These participants were followed for all cancer mortality. Cardiorespiratory fitness was estimated from non-exercise models based on age, BMI, waist circumference, heart rate, physical activity, and smoking status. Estimated cardiorespiratory fitness was further grouped into quintiles. Hazard ratios were calculated from Cox proportional hazards models for the relationship between cardiorespiratory fitness and all cancer mortality. During approximately 20 years of follow-up, 455 cancer deaths were registered. After adjustment for race, ethnicity, age, educational level, current smoking, hypertension, diabetes mellitus, and hypercholesterolemia, each one metabolic equivalent increase in cardiorespiratory fitness was associated with 30% and 27% risk reduction for all cancer mortality in men and women respectively. When estimated cardiorespiratory fitness was categorized into quintiles, hazard ratios were reduced across incremental quintiles in women. The estimated cardiorespiratory ratio was inversely associated with all cancer mortality in quintiles 2 and 4 in women. However, none of the hazard ratios reached statistical significance in men. Thus, at least for women, cardiorespiratory fitness associates with less all cancer mortality. As concluded by the authors, more research is needed to evaluate the association between cardiorespiratory fitness estimated from non-exercise equations and all cancer mortality in men, as well as a dose-response relationship between estimated cardiorespiratory fitness and cancer mortality. The third highlight is a review article which describes short telomere syndromes caused by inheritable gene mutations resulting in decreased telomere lengths and accelerated aging syndromes. In this syndrome, organ systems with increased cell turnover, such as the skin, bone marrow, lungs, and gastrointestinal tract, are commonly affected. It is authored by Drs. Mangaon, Carr, and Patnick from Mayo Clinic in Rochester, Minnesota. Telomeres are hexanucleotide tandem repeats at the end of chromosomes that protect them from degradation during aging. Telomere losses occur over time and contribute to the process of aging. Telomere attrition occurs at an estimated rate of 50 to 150 base pairs per cell division. Once telomeres become critically short, the ends of chromosomes are exposed as double-stranded DNA breaks occur, resulting in the DNA damage response, p53 activation, senescence, and apoptosis. This forms the basis for telomere length, representing the molecular clock in human beings. Shortened telomeres are commonly associated with bone marrow failure syndromes, including aplastic anemia. Among these, the classical telomere disorder that presents in early childhood is dyskeratosis congenita. Associated features may include pulmonary fibrosis, emphysema, liver cirrhosis, lacrimal ductal esophageal and urethral stenosis, premature graying of hair, avascular necrosis, periodontal disease, and a risk for epithelial and hematologic malignancies. Telomere length can be measured by several methods. Flow cytometry fluorescence in situ hybridization provides the initial screening test. Mutational analysis for genes that cause the syndrome can then be performed using next-generation sequencing assays. Several mutant genes have been identified affecting the telomere protein complex or telomerase, resulting in a dyskeratosis congenita phenotype. These genes include DKC1, TERT, TERK, among others. In 40% of cases with this syndrome, gene mutations cannot be identified. Treatment requires a multidisciplinary approach. Organ transplant remains the mainstay for treatment of organ failure associated with short telomere syndromes, for example, allogeneic hematopoietic stem cell transplant for bone marrow failure syndromes, and lung and liver transplant for respective organ failures. Androgens are used with success in patients with aplastic anemia with reported hematologic response rates of approximately 50%. A recent clinical trial reported that in patients with short telomere syndromes, danazol administered for 12 months reduced telomere length attrition and stabilized pulmonary function. Mayo Clinic has established an inherited bone marrow failure precision genomics clinic to aid with the diagnosis and management of inherited bone marrow failure syndromes, including short telomere syndromes. Short telomere syndromes are suspected when patients present with or have a strong family history of premature graying of hair, idiopathic pulmonary fibrosis, premature emphysema, or idiopathic interstitial pneumonia, unexplained cytopenias or bone marrow failure, nodular regenerative hyperplasia or cryptogenic cirrhosis of the liver, along with other stigmata of short telomere syndromes. Patients with telomere lengths greater than the 10th percentile are unlikely to have a short telomere syndrome, and those with telomere lengths in the 1st to 10th percentile range may have a short telomere syndrome. Advances in understanding telomere biology and the use of gene therapy to augment impaired telomere function are exciting future prospects. You can access these highlights and editor's choice articles free of charge during the entire month of July. When you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you will see other free content and articles published online ahead of print. You can also find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find author interviews, 60 seconds video article summaries, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website at the home page as well as through iTunes. You'll also find our Pioneers and Legends video interview featuring Dr. Donald Schultz. And finally, our website lists many news stories that are based on articles published in Mayo Clinic Proceedings. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.